This chapter is going to look at the somatosensory function and do a little bit of review about that. You should have had some knowledge of this having taken anatomy and physiology and some of your other science courses. Then we're going to look at specifically how pain is perceived and how the body recognizes pain. Then we're going to look at different types of headaches. And finally, we're going to do just a quick review about the differences in how we assess and deal with pain in children and older adults. We have millions of nerve endings in the skin and other regions of the body that are constantly providing information about our body to the brain. Specifically, we have three types of neurons that vary in distribution and function as far as what type of sensation they detect. With the general somatic afferent neurons, they're distributed widely through the body and can detect pain, touch, and temperature. Special somatic afferent neurons are located primarily in the muscles, the tendons, and the joints, and these neurons sense our position in space and assist with movement. And so when I talk about position in space, I'm talking about things like, are you standing up? Are you sitting down? Are you laying on your side? Are you laying on your back? Are you upside down? That's what I mean when we say our position in space. The general viscerant afferent neurons are those that have receptors in various visceral structures that sense fullness. So think about when we say visceral, we think about our internal organs. So the structures that sense fullness would be things like the bladder and the bowel, or discomfort. Discomfort could be our sense of that we're hungry. Um, and then we have the first order. And first order is the receptors. Those are usually out in the periphery. And then the second order neurons are those that transmit the messages to the brain. So the first order sends it up to the spinal cord, and then the second order transmits that message to the brain. In other words, the spinal cord sends that message on up to the brain. The third order neurons are located in the brain. Your book talks about your sensory units. And basically what we're talking about when we say modality of sensation, we're talking about what do these particular neurons feel. And so we have the discrimination touch ones. Other people might use the word fine touch. It tells us whether something is big or little, whether it's square or a circle, whether it's sharp, whether it's prickly, whether it's soft like a cotton ball. Those are the things that we are able to sense with discrimination touch. Obviously, with temperature, it's going to tell us when something touches us that's hot or cold, or warm and cool. And then we have the sense of movement of our limbs and our joints. Where are we in space? Is our hand up over our head, or is it down by our feet? Are we sitting or are we standing? Are we hanging upside down? That's what this sense of movement is telling us. And finally, we have nociception, which is just a big word for the sense of pain. All four of these modalities of sensation share the dorsal root ganglion neurons for function. However, they send different types of information or codes up that ganglion to the brain. One thing that's interesting to me is the facial and the cranial sensations that we have do not come from these nerves that are lower on the body. but they come from the trigeminal sensory neurons in the face. On the next slide, when we're looking at dermatomes, if you look at it, the face is white because it doesn't follow those dermatomes. It uses these trigeminal sensory neurons. One of those charts that I've always found fascinating whenever I've seen it, and it's called a dermatome chart. And the chart demonstrates which of the dorsal root ganglion pair is responsible for the somatosensory information from that portion of the body. It also demonstrates where those root ganglion are sending the information to the spinal cord. So if we have injury to an area on the spinal cord that, like for instance, we can see how this particular chart is divided into blue and green and yellow and kind of a pinky peach color. If we had injury to the spine at that yellow area, which is our lower part of our back, then we would have decreased sensory perception below that area. If it was up in the green area, it might, like towards the upper part of the thoracic area, then we would have we would have decreased sensation to the lower part of the thoracic area, the lumbar area, and the sacral areas as well, and all of the innervation to the parts of the body below there. So you kind of get an idea that if somebody had a spinal injury, this is the part of the body that would be affected by it. It also means that if you have a pinched nerve, which is also an injury, but it's compression on the nerve, then depending on where that falls, you can see how it might affect the hands and arms or the legs. And like when people talk about having sciatic nerve injury or sciatic pain, often that's in this peachy area of the lower spine, and you can see why they would have pain that runs down the back of their leg, because that's where the innervation for the back of the leg is. So this is just one of those kind of interesting things, but just have a general idea that depending on where the injury is in association to these dermatomes, that's the area that's going to be affected by it. Again, some of you can learn more by visualizing things, and so I've included some of these things into the lecture just so that you can visually see things, because it makes more sense to some people with that. So when we look at the discriminative and the anterolateral pathways, what we know about them is both pathways work together to give a total sensory input. That if you look at how the information is conducted through the various pathways, and then on top of that, where it's interpreted up in the brain, you can see that that there's very different pathways involved, which is why we interpret the information very differently. The discriminative pathway is for rapid transmission of sensory information. Remember, looking at that picture, that you could tell that there wasn't as much involved. It was very straightforward, kind of a shortened area to get to where it needed to be. It takes into consideration our spatial orientation. Remember our space, where we are in space. It also is important which is how we sense size and shape of something based on touch without seeing it. We also refer to this as fine discriminatory touch. If we are lacking that, either the sensory information is unable to be um, transmitted into the brain where it needs to go, or the brain itself is incapable of interpreting the sensory information that's being sent to it, then we have something that's called astroagnosis. And that means that we we still are not able to tell you, like if I put a ball in your hand and you were feeling it, your brain would not say to you, there's a ball in my hand. So that's what this astroagnosis is. The anterolateral pathway is slower in conducting. Um, it's responsible for pain, for thermal sensation, for crude touch. In other words, it means you can tell that something's in your hand, but you can't tell what it is. The discriminatory is what tells you this is soft, or this is rough to the touch, or this is prickly. Um, but the anterolateral pathway just says something's here. The other thing that it controls is general pressure. And with general pressure, we're not getting any information about exactly where it is or what the source of the pressure is or how intense the pressure is, just that there's some kind of pressure there. So you might say that this particular one, as far as touch and pressure is concerned, is not as detailed in the information that it relays to the brain. Um, this anterolateral pathway is divided into two tracks. One is known as the paleospinothalamic tract, and it goes directly to the reticular activating system. And it affects your arousal, your mood, your attention, and your startle. It's responsible for the autonomic responses of increasing heart rate and blood pressure and dilating pupils that are associated with your fight or flight. It's also responsible for your emotional responses to sensations, like negative responses to pain or the pleasant sensation of somebody special holding your hand. The neospinothalamic tract also goes to the thalamus, but it also goes to the parietal cortex. And that allows us to localize where something is or to identify that we have pain. So we've talked about everything going up to the brain, so now let's talk about where these sensations are processed in the brain. The primary somatosensory cortex receives the primary sensory information by direct projections from the thalamus. And it is able to actually identify the sensation. Up to this point in time, when it falls into the thalamus, we have a sensation that something has happened, but we haven't actually been able to identify what that sensation actually is. That happens in the primary somatosensory cortex. And you can see on this particular picture that that is this sort of lavender colored area in the brain. The association cortex, which is the darker blue area in this picture, gives the sensation meaning. In other words, in the past we've often said that babies feel no pain. That's because if we ask a 2-year-old if they remember having pain when they were a baby, they can't remember it. And the reason they don't remember it is they don't have words to describe it. It doesn't mean that the brain itself doesn't process and put things together visually to say, oh, if I touch this, I have an unpleasant feeling, and the next time they touch it, they have it again, and they go, oh yeah, last time I touched that, I had that same feeling, and so now I remember I shouldn't be touching that. But infants don't have words to put to it, so you can't put a memory, you can't express a memory to it. But the association cortex, as we get older, actually puts emotion and memories to incidences that have happened to us so that we don't do those same things again. So if something happened and you touched a hot pan and your hand got hurt, the next time you see a hot pan, you're going to say, oh my goodness, that hurt really bad. I'm not going to touch that. I need to get that pot holder so that my hand doesn't get hurt. So that's what happens in the association cortex. It gives a sensation meaning to what has happened to you when you touch something. So here's an example of a question that might be on an exam. And so think about what answer you would answer. And here's your answer with its rationale. Second order neurons travel from the spinal nerve root to the medulla oblongata, or the brainstem or hindbrain, depending on how you want to phrase it, and cross over to the thalamus on the opposite side of the brain. So let's talk a little bit about these modalities, or how these sensations get to where they're supposed to be. We have tactile sensation. Tactile is touch, pressure, and vibration. The lack of tactile sensation leads to numbness. So we might lose one type of our tactile sensation, but hopefully we don't lose all of it, because if we lose all of it, we have just a numbness in our hands. There's various specialized tactile receptors in the skin and in deeper structures of the body. For instance, the free nerve endings are responsible for touch and for pressure. The Meissner corpuscles are encapsulated nerve endings that are present in non-hairy parts of the skin. So in other words, the palms of our hands, our fingertips, our lips, the soles of our feet, and they are receptors to fine touch, or our discriminatory touch, where we can tell the difference again between sharp and soft, or wet and cold, or warm and dry. Those are what we're feeling with the Meissner corpuscles. The Pacinian corpuscles are immediately under the skin and also deep in the fascia tissues. And they're stimulated by rapid movements. And so whenever there's vibration present, these Pacinian corpuscles say, oh, there's a vibration going on here. And that's how we're able to sensate, to feel that there's vibration. The Merkel discs are found also in the non-hairy parts of the skin, and they are able to send steady state signals for a continuous sense of touch against the skin. So this would be something like if you've got a book in your hand and you're not letting up on it, and so there's this pressure of the weight of that book that's there. And as long as it might get used to the idea that, oh, there's a book in your hand, but it still senses that the book is there. Your hair follicle end organs are unmyelinated fibers that entwine around most of the length of the hair follicle, and it detects movement on the surface of the body. So this is how we tell when the mosquito comes along and lands on our skin, or how we feel a breeze moving the hairs on our arms. Yeah, I think it's interesting because I hear about people that go out and shave off the hairs on their arms, and what they do is they eliminate that sense of feel that tells them what's going on in the world around them and close to them. And I'm thinking they probably get bitten by bugs a whole lot more often since they don't have those little hairs. to warn them when that little bug comes down and lands on them. The ruffian end organs are also in the skin and the deeper structures, and in this case, in the joint capsules itself. And it signals a continuous state of deformation, like a heavy and continuous touch or pressure. So this is that sense of I've been sitting here for a while, and maybe it's time to move now. Um, you know how your behind kind of gets sleepy because we've been sitting in that same position for so long, or maybe, like I was talking before, we've got something sitting there and I don't just forget that it's sitting there. It's not like it returns to normal and I think that nothing is there. I'm always aware that something of weight is in my hands or that something of weight is sitting on my leg. So these tactile sensations are conducted primarily through the discriminatory pathway, but it can also go, some of them also go through the anterolateral pathway. So slower pathway through the anterolateral, faster pathway through the discriminatory pathway, which is a good thing because if my hair follicle end organs were not sending that information quickly up to my brain, I wouldn't be able to reach over and slap that mosquito before it goes flying off with my blood. Another sensation that we have is thermal sensation or warmth and cold. And what's interesting about this one is not only do we feel cold and warmth, but we also feel pain in association with cold or warmth with this particular modality. And with pain, the pain side of it, we only feel pain from the cold or the warmth when it's extreme cold or extreme heat. This particular modality responds rapidly to sudden changes. So if I stick my hand down in ice cold water, I'm very quickly going to know, oh my goodness, that was cold. But if I leave my hand in that cold water, over the next few minutes, it's going to go, yeah, it's cold, but all right, whatever. And we'll see the opposite in people that like to take really hot baths. Initially, when they get into the bath water and it's really, really hot, they'll kind of go, ooh, that's kind of hot. And then at the next couple minutes, as they're sitting in there, their body gets used to that really hot water. And it's not that they aren't aware that it's still hot, but they don't perceive it as being as dramatic as when they first got into it. These are conducted through the slower anterolateral system, which is why we don't have this instant, almost reflexive movements to get away from this cold or hot perception. Proprioception is your position sense or where your body or your body parts are in space, like what we talked about just a little bit ago. So with the proprioceptive receptors, we have stretch sensitive receptors, so they definitely are sensing when the tissues are stretched. We have the ruffian end organs, the Pacinian corpuscles, and the Merkel cells, which we talked about earlier in the previous slide as percepting as having a perception of touch. Well, they also signal postural information to the brain as well. And these are conducted through the discriminative pathway. The same pathway as touch is sent to the brain. Now that we've reviewed how all of these sensations are sent to the brain and interpreted in the brain, let's look at pain specifically. And what is it about pain that makes it so different from the other sensations that we feel? And why does it have its own sensory section of the body? Well, there's several theories about that, and many people have offered theories about how and why we feel pain. One theory is the specificity theory, and that is basically what we've been talking about, that there's special pain receptors that feel pain, or nociceptors. And they also feel with that there is also special areas in the forebrain where we interpret or experience pain, which is pretty much what we've been saying up to this point. Then there's those that look at what's called the pattern theory. And with that, it's that the nociceptors share pathways with other sensors, but that the patterns are different. And that's why the brain interprets them differently. And that the sensory receptors create pain pathways when the stimuli that's going through them are too strong, which is kind of what we were saying when we were talking about the thermal receptors, that perhaps that's what's going on and why we have a pain aspect to that particular type of sensors. We talked in pharmacology about the gate control theory, where pain is carried by distinct fibers in the spinal cord, and that stimulation of other nerve fibers close to the injury is able to close the gate, allowing the pain to be perceived as less intense. More recently, the same author has come up with this neuromatrix theory, or the body self neuromatrix, which basically says that pain in and of itself is no big difference than any other sensation, except that when that information gets to the brain, that the brain identifies it as pain, and that there's a genetic and sensory influence that determines the architecture of each individual's neuromatrix, and that neuromatrix, because of those genetic and sensory influences, influences how we interpret pain. Some of the other influence how the brain identifies and interprets pain can be your family background, how your family raised you to identify pain, or how your culture tells you pain is to be interpreted or expressed. And so, in a way, it's a more holistic way of looking at pain, since we know that different cultures seem to respond to pain differently than other cultures, and that even within a culture, different people from different families respond to pain stimuli differently. This particular slide is just going to review vocabulary and some other concepts in relation to pain. And so, definitely these are concepts that you need to know. Nociception is the definition of pain sensation in the body. Neuropathic pain is a direct injury or dysfunction of the sensory axons of nerves in wherever that injury is in the body. Your pain threshold is the point at which a nociceptive stimulus is perceived as being painful. Some people get pain threshold and pain tolerance confused. Pain tolerance is the maximum intensity or the duration of pain that a person is willing to endure before that person wants something done about it. So you can see the difference between threshold and tolerance. Threshold is that point that you go, yeah, that hurts. versus the tolerance where it's now so bad or it's lasted so long that I want to do something to make it stop now. I don't want you to spend a lot of time with all of these knowing which fibers carry which pain impulses. Again, this is one of those things where it's a nice to know thing, but you're not going to be coming down a hospital hallway and have some doctor say, so which fibers carry which pain uh, signals do the alpha delta fibers carry? Nobody's going to ask you that. Nobody's going to ask you that on NCLEX, and I'm certainly not going to make a big deal about these on any kind of test. The alpha delta fibers are large myelinated fibers, and impulses travel very quickly through them. They are fast pain impulses. They release glutamate at the synapses with the spinal neurons, and that has a lot to do with why you perceive this as being painful. The C fibers are the smallest nerve fibers, and they're unmyelinated. The impulses are slower. They will sometimes refer to these as being slow wave pain. Um, these fibers can cause neurogenic inflammation, meaning that we have the whole inflammatory process happening in the around this nerve that's feeling that pain. It also releases glutamate and something called substance P. The substance P tends to prolong and enhance the action of the glutamate, so the pain tends to be there longer when that's present. We've already talked about these different types of pain in pharmacology, so I'm not going to spend time going over them again. Both your patho book and your pharmacology book tells you the definitions of all of these. If you're forgetting what they are, so but we won't just, no, no lecture on pain would be complete without a review of the types of pain. As far as pain management goes, I'm definitely not going to be going into great detail about these since we've already covered that in pharmacology and had 3 chapters of your book about that. Or was it just 2? Anyway, we're not going to review the pharmacologic treatments. You know the non-narcotic, the narcotic analgesics, the depressants, anticonvulsants, and muscle relaxants associated with those. Uh, Assessment, we learned that back in fundamentals. We know we have to look at the nature of the pain, the severity, the location, and whether or not it radiates. Some of the non-pharmacologic interventions, we don't spend a lot of time talking about these very often. So just a review of those. We have cognitive behavioral interventions. Um, we can use physical agents like the stimulation to an area around a injury, back to that whole gait theory of why we rub our hand or our foot after there's been an injury to it. We have electroanalgesia. We also call that TINS. And acupuncture is another way that we can use non-pharmacologic interventions. Sometimes it may just be changing the patient's position so that they're not lying on an injured area, or we're elevating the injury, or we're moving the body so that there's less pull on the muscles that have been injured. So those are non-pharmacologic interventions. In some cases, we do surgical treatments, And the surgical treatment may actually cure whatever it is that's causing the pain to be there. Like if you have a brain tumor, it may cure your headaches to get that tumor out of there. Or in other cases, it may be a way to manage pain. For instance, they're doing things now where people with lower back pain are having a TENS like machine um, placed under the skin that provides that electrical stimulation to the spinal cord at the area on the dermatome where it needs to be for the pain that they're experiencing, and it's surgically embedded into the body, and so that helps to manage their pain. So here's another slide with vocabulary words for you. And these specifically are talking about altered pain or altered sensitivity. Hyperesthesia is increased sensitivity to stimuli of the sense of touch. So, in other words, when you touch somebody, they are much more sensitive to you having touched them, and they may feel that you have touched them much more deeply or harder than what you think you have touched them with. Hyperalgesia refers to increased painfulness above what would be expected for the amount of injury that's there. Hypoesthesia means reduced sense of touch sensation. So you've touched somebody, but they don't feel the touch as strongly as what you would have expected them to have felt it at. Obviously, anesthesia means that you can't feel the touch. So think about anesthesia. You don't feel anything. Local anesthesia makes it so that you're numb and you don't feel what's going on there. So that's a good way to remember that word. Hypothermia means we have reduced temperature. And most of us think about hypothermia as being the whole body, but you can have hypothermia of just one area of the body. Of course, the rest of your body's going to try to warm it up by putting that nice warm blood up there, but hypothermia refers to reduced heat. Athermia means that there is no temperature there at all. It's lost, it's gone. There's nothing there. A means none. Thermia means heat, no heat. Hypoalgesia refers to reduced pain sensation, and in some cases, that's all our medications do for our patients. It reduces the amount of pain that they're feeling. Analgesia, it means that we have no pain sensation. And so if you think about most of our pain meds are analgesics, so that it takes away their pain. Allodynia refers to pain after a non-noxious stimulation. So the thing that I think about most when I see this definition and this word is fibromyalgia. And if you touch somebody who has fibromyalgia, they will interpret that soft touch that you've given them as being very painful, and yet you've not touched them in a way that should have hurt them. Here's another question to think about that could possibly be on a test where you need to know the definitions of your words. So think about this question for a second here. And of course, here's your answer to the question that morphine is a prototype type opioid. It's a CNS depressant, narcotic that is commonly used to relieve the sensation of pain, which is analgesia or the absence of pain. This slide is talking about the causes of neuropathic pain. And a lot of people wonder why people have neuropathic pain. And it can result from pressure on the nerve. So if somebody's had an injury to their spine and the bones of the spine are pushing up against the nerves, then they may have neuropathic pain from that area on the spine on down, or it may refer down that dermatome. If there's a physical injury to the neuron, so there's inflammation in the area of that neuron is located, you're going to have neuropathic pain. If there's a chemical injury to the neuron, maybe we've given a medication and we've hit the nerve instead of hitting into the muscle. It would be a combination of a physical and chemical injury to the neuron. If there's an infection, think about somebody who has meningitis. They have horrible, horrible headaches because the neurons in their brain are being affected by the infectious process. If there's ischemia, so we're not getting oxygen to that nerve, there is often pain. And think more about diabetic neuropain, especially in the feet, when we're thinking about ischemic pain and neuropathic pain. And of course, if there's inflammation of the nerve, we talked that, and basically that's what we're looking at with infection, is that there's the inflammatory process going on around those nerves. So now we're going to talk about some types of pain, specifically more of the neuropathic types of pain. Neuropathic pain is described as pain that comes from pathology of the nervous system, and neuralgia is one form of that. It is defined as severe, brief, often repetitive attacks of, your book uses the word lightning-like or throbbing pain along a spinal or cranial nerve that's precipitated by stimulation of the cutaneous region that is supplied by that nerve. Cutaneous talks about skin or the structures just under the skin. The first one that they mention here, which I have to say I've never heard of before, is called the trigeminal neuralgia or a tic douloureux. It is a facial tic or spasm that's associated with stabbing pain that's usually limited to one of the branches of the trigeminal cranial nerve, which is cranial nerve 5. They really don't know what causes it, but it's thought to be a neurovascular compression, and it can occur as part of MS or when tumors are being formed. The treatment is medication, and I'm going to say this wrong, I'm pretty sure, but it's carbamazepine, which is an anti-seizure medication. It is considered to be the first line of treatment for the trigeminal neuralgia. They can also do some surgical interventions. Since it's caused by neurovascular compression, they can do surgical treatment that is involved in releasing the vessels from whatever is compressing them, which could be scar tissue surrounding the nerve root or the vessels. They can do a permanent blocking of the nerve so that you just don't feel anything there anymore. They've been doing some treatments with Botox and feel that may be helpful in the future. But according to your book, that wasn't conclusive yet. Postherpetic neuralgia is when somebody's had chickenpox. Chickenpox is caused by herpes zoster, and in most cases, these occur in the elderly because as we age, our system is not able to keep that infection under control anymore. Basically, what happens after we have chickenpox is the virus decides to live down in one of our nerves, and it stays down in that nerve unless our immune system becomes weakened and can't keep that under control. So as we age, our immune system naturally becomes more weakened, and so people tend to have more instances of shingles as they age than when they're younger. And what happens with it is there's a localized vascular eruption and exaggerated pain at the site where it comes up. So if you think about it, when you have chickenpox all over your body. And you have these little lesions, like this picture shows, everywhere, all over your body. They make lovely little scars and the like. And then as you're healing, the herpes zoster virus goes down into this one nerve and stays there. And so now it's no longer all over your body, it's just in this one nerve region. Think about that picture of the dermatomes. Whichever nerve it's decided to settle down into, that's where that person is going to get their shingles outbreak. For a lot of people, that's around the sides and the rib area. I know of some people that have gotten it up around their eyes because it's gone into the optic nerve that can cause blindness with that. So it settles in that one nerve. Every time they have a relapse of their zoster so that they get it again, it's always going to be in that same area and in that same dermatome. The drugs that we use to treat it are antiviral drugs, acyclovir or valcyclovir. Those drugs don't cure you of the virus, but it causes the virus to die faster, and it causes the infection to not last as long. They can use topical lidocaine to relieve some of the pain, and they may give amitriptyline as a way to help with some of the anxiety associated with it. Amitriptyline also has some antihistamine action to it, and so it can help with the inflammation that's going on as well. Some people, if they're having severe pain, they may do a nerve block to relieve some of the pain during the acute phase of their shingles. Currently, there's a new vaccine to prevent shingles. It's recommended for adults over the age of 60. And if you look, a lot of adults over the age of 60 have had chickenpox because there wasn't really a good chickenpox vaccine back when they were young. And so that is something you see a lot of commercials on TV about people getting this shot for their shingles. I can't remember the different stars that have been on these commercials lately because they've had a case of shingles and they never want that to happen again. Another type of neuropathic pain is called complex regional pain syndrome, or CRPS. It's caused by autonomic and vasomotor instability. There's two types of it. Both types are associated with pain and mobility problems that are more severe than what their injury warrants. They don't really know what causes it, but it's associated with abnormalities of the sympathetic nervous systems. New research is looking at autoantibodies against the autonomic nervous system structures. So, in other words, it's almost more of an autoimmune type disease. Treatment is early mobilization after an injury, physical therapy, and pain management involves standard medications used for neuropathic pain. Short-term corticosteroids might be used. They can do neuroblockades or electrical stimulation. TENS of the spinal cord could be considered in some cases. Phantom limb pain is a really interesting disease, so to speak, in that 95% of people that have had amputations will experience it at one time or another. Uh, what happens with it is they get a tingling or a hot or cold or heaviness feeling in in that the brain interprets to be in an area that no longer is on their body. And that's followed by burning, cramping, or shooting pain. And that tends to be more common in the first 6 months after amputation, but it can occur at any time. Recently, I have a friend that has an above the knee amputation, and she's never said anything about having phantom limb pain. But a week or so ago, she made a post about it is so real and I hurt so bad. There's a lot of theories of the cause, but one of them is this, that the end of the regenerating nerve becomes trapped in the scar tissue of the amputation site, and or that there's spontaneous firing of the spinal cord neurons that have lost their normal sensory input. So, in other words, it's almost like they're searching, why am I not getting input? Or there's changes in the flow of signal through the somatosensory area of the brain. Again, it's almost like the brain is saying, wait a minute, there's supposed to be flow coming through here. Why am I not getting any information from that part of the body? The treatment is sympathetic nervous system blocks, TENS units to stimulate the nerves innervating that area, or relaxation training. Um, Honestly, there's no real good way of treating it, and most people that suffer from that, I really haven't heard of them getting much relief until that decides to die down. The other day we talked about migraine headaches a little bit. We're going to talk about several different kinds of headaches, but migraines is a major problem here in the United States. They affect 20 million people in the U.S., and that amounts to about 18% of women and 6% of men. So you can see it tends to affect women more than men. We'll talk a little bit later about why that is the case. Um, they're divided into two types, without aura or with aura. Uh, about 80% of people with migraines have the type of migraine that has no aura. They are pulsative, throbbing, unilateral headaches that last anywhere from 1 to 2 days. And when we say unilateral, it means that if you were to draw a line down the middle of your nose and down to the back of your neck, it would only be on one side of your head. It wouldn't be on both sides of your head. It's aggravated by nausea and vomiting and sensitivity to light. And the ones with aura have the same symptoms, except they know when they're going to get the headache because they get sort of this warning ahead of time. And the warning ahead of time can be that all of a sudden, visually, they see flickering lights or spots, or they may have a blind spot, or they may not be able to just have blindness on one side of their eyes. They may have a feeling of pins and needles or numbness. They may know what they want to say, but for some reason they can't get it to come out the way they want it to come out. And there may be other neurologic symptoms. Um, Usually these things happen 5 to 20 minutes prior to the headache, and they can last anywhere from 5 minutes to an hour. I happen to be one of those people that migraines, and for myself, I get a blind spot to start out with, and I just, I might, it might be peripheral, it might be central. It varies from headache to headache. I've been known to get numbness across my cheek on the side that's going to be affected. When I was pregnant with my oldest daughter, I had a migraine that caused me to not be able to speak right. So I was at work and they wouldn't let me go home. And they said, well, answer the phone. And I couldn't tell the person what I needed to tell them because my speech wasn't coming through correctly. It's a very scary thing. When you first start getting them, if you're old enough to really understand what's going on, you start wondering if you've got some kind of brain tumor. And, people will say, oh, it's just a migraine. But there's always this thought in the back of your head, well, maybe it's a brain tumor because a lot of these symptoms are really similar to what you get with brain tumors. There are retinal migraines, and these are rare. They're associated with visual sensations of sparks or flashes of light and blindness. They only affect one eye, and then they're followed by a headache. There's also a form called transformed, and these are a combined type headache that is usually you have symptoms like a sinus headache or a tension headache along with all of the migraine parts that go with it. Obviously, not a pleasant thing to go through. In children, and these can start affecting children at a very young age, but they usually don't like to give them the migraine diagnosis until they've ruled out other things. But they need to have 3 of these symptoms that I have listed here: abdominal pain, nausea, or vomiting, throbbing headache, unilateral location, an associated aura, and a positive family history. Migraines tend to run in families. I have migraines. I started getting them when I was 10 years old. Both of my daughters started getting headaches about the same age and have the same kind of aura and everything, just like I do. My son started getting headaches when he was a little bit older, but they tend to run in families. I thought I was the only one in my family that had them because nobody else in my family ever talked about having these headaches. And even my mother never said anything to me like, Faye, it's okay, mommy gets these too, or anything like that. I've figured out over the years that my mom's had migraines for years and years and years, and she just never acknowledged them. They don't really know what causes migraines, and again, there's a lot of theories of what causes them, but there is some things that are common with them. They do know that the trigeminal cranial nerve 5 is activated during a migraine, and it results in activation of painful neurogenic inflammation within the meningeal vasculature versus whether or not there's vasodilation of the meningeal blood vessels as the cause of the inflammatory process. Either way, you end up with inflammation of the meningeal vascularization. And that has a lot to do with the headache, and also it has a lot to do with the after effects where people, the pain of the headache is gone, but they still feel like there's a fullness inside of their head, and that if their head drops below the level of their heart, they get this throbbing pain in their head that goes away as soon as their head gets back up above the level of their heart again. And that has to do with the fluid that has escaped those vessels as into the tissues as part of the inflammatory process. We know that fluctuation of hormone levels, particularly estrogen, has a lot to do with people getting migraines, which explains why there's a much larger number of women that get them than men. Um, and often women will say that they have more migraines during pregnancy when the estrogen levels are high as well. Dietary triggers have been noted in some people, and they feel that it's actually a chemical trigger in those foods rather than an allergy to them. There's preventative treatments, and those are usually the best way of trying to deal with these. Preventative treatment includes things like avoidance of triggers. If you know that certain foods tend to make you get migraines, then don't eat those foods. Staying on a regular pattern day after day after day is a really good thing. So if you normally eat at 8 o'clock in the morning, noon, and 5, you don't want to suddenly start eating at 6 in the morning and 1 in the afternoon and 9 o'clock at night. Because those are the kinds of things that tend to make the migraines worse. I always kind of relate it to keeping my blood sugar stable, that I don't have these ups and downs that come from not eating on a regular schedule. Uh, Having regular sleeping hours is also really important. A lot of people will note that they have a migraine hit after they've stayed up late on the weekends, and a day or so after that happens, they'll have a migraine. So keeping regular sleeping hours and eating at regular times tend to help to control it. Stress control is important because usually what people will say is 2 or 3 of these things all hit at the same time. And because they're all hitting at the same time, that seems to trigger their migraines. So if they've been eating a little irregularly, their sleep has been off a little bit, and they're stressed, they may find that they're getting migraines during those times. One of the other preventative things that they can give are beta blockers. Specifically, Inderal tends to be one that they give. Antidepressants have worked with some people, and anti-seizure medications have worked with other people. As far as abortive treatment, that means you're taking something after you realize that the headache is going to come on. Non-pharmacologically, getting into a quiet, dark room tends to help the headaches not hit quite so hard, and maybe be relieved a little bit faster. Sleeping tends to make the headaches go away. The first line medications are aspirins or NSAIDs, specifically with caffeine. Your book talked about acetaminophen as a treatment, but due to the inflammatory process, it's usually not a very helpful medication. The NSAIDs really act on the prostaglandins that are being released during the migraine headache, and so that tends to help keep the headache from happening, or to reduce the amount of time that you're feeling pain. I know for myself, I actually do this um, as my aura comes on. I get myself something like 20 ounces of some drink that has caffeine in it. and then I take a higher dose of NSAIDs, and between the two of those, that will get my pain levels under control, at least enough so that I'm functional. If I allow my pain to get worse, my pain will actually get me to the point where I throw up. So that's one of the reasons why that tends to work. Sumatriptan, which is a serotonin receptor antagonist, works for some people. And ergotamine derivatives, this is one of the older treatments for migraines, but tends to work with some people really well. Antiemetic medications also are helpful because, again, if the pain gets bad enough, people tend to get nauseated and throw up. So, taking these medications that help you not to throw up can be helpful. In addition, some doctors will actually combine medications that cause the motility of the gastric contents to move along faster, because with these headaches they tend to slow down, which is why they think that you have the nausea and vomiting. And so that causes these other medications to be absorbed in a more normal fashion and faster, so you get relief faster. So there's a lot of different ways that they deal with that. The book talked about the fact that because of the nausea and vomiting, that having other ways of taking these medications, like intranasal treatments, are often better for people than other. One of the things I also wanted to mention, some people it becomes so severe that there's actually, ERs will have a migraine cocktail that they give people with severe migraines. It usually has a barbiturate in it, and it has an opioid in it, to relieve their pain. And an antihistamine, as I remember correctly. It really is nothing to poo-poo about, because people really do get these very severe headaches. Um, some people, if they use their abortive medications too often, or they drink a lot of, if they normally drink a lot of caffeinated drinks, or use NSAIDs frequently for other things, those medications and combination of medications may not work as well for them, because their body is used to it and they don't respond as much. I know for myself, when I realized that caffeine was something that was medicinal for me, I stopped drinking caffeinated drinks, because I wanted to make sure that when I have my migraines, that the caffeine relieves my migraine. So that's advice that you may give to somebody, that when if they get a lot of migraines, that they might want to reduce the amount of coffee or caffeinated sodas that they drink, so that the caffeine can do a better job of acting on the blood vessels in their head and making them constrict better for them. Because we know with the inflammatory process, you get dilation and increased permeability of the vessels. And that's what's happening with the migraine as well. And so with caffeine, it causes those vessels to become more constricted, and they are less leaky out into the tissues. Some other headaches, cluster headaches are uncommon. They do occur in about 1 in every 1,000 people. They're more common in women ages 20 to 40. The headaches tend to come in clusters. So they go months without any headache at all, and then for days, weeks, all of a sudden they're having headaches very frequently. And then they go away, and then they don't have them again for a long period of time. As far as the symptoms, there are things like pain over the eyes and the temporal areas that radiate towards the trigeminal nerve, which is the area over your temple, your cheek, and your gums. They're associated with feeling restless, having agitation, having redness and tearing of the eyes, which also goes along with nasal congestion, runny nose, forehead and facial sweating, miosis and ptosis, and eyelid edema. They're often mistaken for sinus headaches. They really don't know why they're caused, but there's a lot of theories behind why they happen. The treatments for them include home oxygen therapy, subcutaneous sumatriptan, intranasal lidocaine to relieve the pain, and preventatively they may give the ergotamine derivatives. They may give calcium channel blockers, corticosteroids, or valproic acid, which is a anti-seizure medication. At one time or another, most of us have had a tension headache. The symptoms are usually a dull, aching, diffuse, nondescript headache. They really don't know why people get those or how they get them. The treatments include non-pharmacologic things like biofeedback, massage, acupuncture, relaxation, imagery, physical therapy, and pharmacologically, you can take aspirin, acetaminophen, or NSAIDs to help relieve the pain. Chronic daily headaches occur 15 or more times per month. They're similar to migraine in some people. The treatment are the same as the behavioral interventions for tension headaches and prevention of medication overuse, because one of the theories with them is that people are using medications to relieve headaches or are taking medications that could possibly cause the headaches too much, and that if you decrease this medication use, then the medications that should take care of the headaches will be able to take care of them. TMJ, or temporal mandibular joint pain, is caused by an imbalance in the joint movement because of abnormalities in bite, so your teeth aren't coming together correctly, bruxism, which is grinding of the teeth, or joint problems. With grinding of the teeth, it's more than just the grinding that's causing the problem, it's actually the tightening of the muscles in the face that seems to be part of the problem with TMJ. The symptoms are referred pain in facial muscles, headaches, neck ache, and earache. So if you think about if your teeth start hurting, a lot of times people will say that they notice that they have that their ears are hurting as well because it refers back to that area. The treatment is correction of the dental problem that may be causing, so you need to go to a dentist and have the dentist put braces on or some type of corrective appliance to help with the grinding or the abnormal joint problems. NSAIDs and muscle relaxers have been shown to be beneficial in some people, and also select application of either heat or cold. And in some people, they'll put heat to start out with, and then they'll put cold on it, or put cold on first, and then put heat. So it's something that people kind of experiment and find out what works best for them. Finally, we're going to talk about pain in children and pain in older adults. because we know that some of the things that we do on either end of the age spectrum is a little bit different than what we would do with people more in the middle. Uh, in children, it's important to remember that they perceive and react to painful stimuli just like adults do. There was once a time period that we felt that infants did not feel pain. I don't know whatever could possess somebody to think that. I think I've referred to the fact that you can't ask a 2-year-old to describe pain that happened to them as an infant because they don't have the words to express it at the time that the pain occurred. Um, we they thought that because the nerves were not myelinated in young children, that meant that they didn't feel pain. But what we found is that their pain may actually be accentuated because the descending inhibitory pathways to the dorsal horn are not as well developed or myelinated as well as they will be later in life. We can find reporting reliability in most children by the time they're at the age of 3 years old. It's important that we use appropriate, reliable pain scales for each age level that we're assessing. For instance, we have one that's known as the PIP scores. It's for premature infant pain profile. NIPS is the neonatal and infant pain scale. The Evendal, which was developed in France and interpreted into English so it can be used here in the States. The FACES and the numerical rating scale are all scales that need to be used on children that are verbal. As far as pain management goes, everyone should be treated as individuals, and children are no different. We can use non-pharmacologic treatments for them to help relieve their pain in addition to or singularly um, with pharmacologic treatment. One important thing that we have to remember with children is that not all pain medications that we use in adults have been shown to be safe in use for children. So we have to make sure that those are being followed. And often, and with children, we tend to give them dosages based on their weight. Where on adult, we may just give us, adults get 1 to 3 milligrams of morphine every 2 to 3 hours, no matter what size the person is, where a child gets 1 milligram, 0.1 milligram per kilogram per dose. So it's important that we're following safe guidelines as we're giving medications to children. Also, some people get very worried about giving children opioids because of the respiratory depression associated with them. And when someone is in pain, they're in pain and they need to be treated with the appropriate pain medication. I've been in the NICU sometimes where somebody said, "Oh, I don't want to give them morphine because they're not on a ventilator." Well, this kid was in severe pain and should have been given morphine because that was the appropriate drug for him, not Tylenol. Tylenol is for mild pain. And so it's important as nurses that we are advocating for our patients so that they're getting the appropriate type of pain medication for the type of pain that they're having. Conversely, we have similar type problems, but on a different level for older adults. Persistent pain or chronic pain is much higher in older adults. They estimate somewhere between 25 to 80% of older adults are having chronic pain. Musculoskeletal, rheumatic, and neurologic pain are primary causes of pain in older adults. that it can have a significant functional, cognitive, emotional, and societal effect when somebody is in pain all the time. Uh, Not only that, but we start thinking about the fact of whether or not these adults are able to give us an adequate assessment of their pain, because we have people that are cognitively impaired. So we have pain scales that are appropriate for cognitively intact people, which include the numeric rating scale and the FACES pain scale. So think about maybe your patient who may have had a stroke, but they are still able to communicate. Maybe you're not able to understand them, but they're able to to point at something. So a FACES pain scale may be appropriate for them because they can take their finger and point to the face that is at the level of pain that they are having. Excuse me. We also have pain scales for cognitively impaired older adults. Oh, one of those is called the Pain Assessment for Advanced Dementia, or PAIN-AD. Another one that I saw listed was Pain Assessment Checklists for Seniors with Limited Ability to Communicate, or the PACS-LAC. There's also a PACS-LAC 2. I got that information from geriatricpain.org. So it's something that we don't want somebody to be in pain just because they can't communicate that to us. We want to look, as far as management, some of the considerations that we need to look at is, what is their cause of pain? Have they been injured, or is this a chronic pain issue for them? What is their health status? Because if they are having kidney problems or liver dysfunction, we're going to have to look at the doses of medication that we're giving them, and they may need to be either increased or decreased depending on the way those drugs are excreted. We want to look at their concurrent therapies. Remember that there's drug interactions. And am I giving them drugs that are competing against each other so that they're not getting the pain relief that they deserve? And then, of course, what their mental status is. As far as treatment is concerned, it's going to be similar to other adults, but we have to look at these other considerations because many older adults are on multiple medications. And it's not unusual at all to find that we're giving a medication for one thing that will make another medication not work as well. And so we have to make sure, or that that medication may cause increased risk of kidney or renal failure or liver failure by giving those two medications together. So we have to make sure that we are aware of the medications that they're receiving. They may be receiving smaller doses because we find that in some cases they are more sensitive to the doses than a younger individual, or they may be receiving higher doses because of liver dysfunction and the lack of their liver being able to metabolize the drug effectively. And so that is pretty much it for this. I do want to mention, as far as non-pharmacologic, because of so many of their pain being related to musculoskeletal or rheumatic type of problems, that we often use heat and cold to treat adjunctively with pain medications with older adults as well. Want to wish you all a good day, and we'll talk to you soon.